And I'm going to also introduce myself, which I forgot the last one. I'm Sharon Terry, the president and CEO of PXE International. And I am delighted that we're able to extend our annual meeting over the whole year. You get much more time with each speaker. You get time to ask questions. We're going to ask you not to bring forward personal questions. General questions are fine, but none of the clinicians or researchers who come to us for these talks are in the position where they can practice medicine on Zoom. You have to see your own clinician for that. And so general questions are great. Personal questions, we would prefer you not to be asking. So I'm going to introduce Dr. Wayne Fuchs, who has been working on PXE for as long as I can remember, and probably before my kids were diagnosed in '94. He's been a real ally and friend of PXE International in the sense of being really generous with his time. He's also been very involved in a number of the clinical trials and has been available to answer questions for me when they come up around the issues with PXE in the eye, PXE in ophthalmology, retinology. So without further ado, Wayne, I'm turning it over to you.
Well, thank you for inviting me and for that kind introduction. So today, I'd like to share with you how PXE affects the eye. I will describe the anatomy of the eye, ocular manifestations of PXE, ways to prevent disease complications, methods for early detection of problems that may need to be treated, the diagnostic tools we use to evaluate patients, and how we treat active disease. I will illustrate some of these principles with case presentations along the way and share some thoughts about future approaches. Let us begin with the anatomy of the eye. As you can see from this diagram, the eye may be divided into the front and back portions. The cornea is like the crystal of a watch, and the light passes through the clear cornea, the pupil, and the lens to be focused on the retina. The image, after being focused on the retina, where most of the significant complications related to PXE are found, you might note this area marked macula, which is the center of the retina. The retina is said to line the back of the eye, but as you can see, it actually is the inner surface of the eye. And so therefore, the peripheral parts of the retina are responsible for your peripheral vision. The macula, where we're more concerned with, is responsible for the detailed vision of your eye. That would be reading, recognizing features of someone's face. The images, after they're focused on the macula, pass through the optic nerve to the brain for interpretation. So if you imagine that there are 1 million fibers in this optic nerve, approximately 500,000 of them come from this small area or the macula, and that is how it is able to provide the detailed vision that we're talking about. This is a detailed cartoon of the cellular layers of the macula. Please note the photoreceptor layer. That's the rods and cones, or receptors. Then you have the retinal pigment epithelium separated from the vascular layer, or choroid, by Bruch's membrane. Bruch's membrane has an elastin-containing layer, which makes it important in the pathology of PXE, which we will see in a few minutes. There are many ocular manifestations of PXE, but most common is peau d'orange, or leopard spots. This disturbance is felt to be a calcified and degenerating Bruch's membrane, which is just beneath the retinal pigment epithelium and in front of the choroid, as you just saw in that cartoon. It can be described as a widespread area of mottling of the fundus caused by multiple indistinct yellowish lesions resembling the skin of an orange. This is the most common retinal finding in PXE, affecting 96% of patients studied and is most apparent in the first 4 decades of life. It is easily seen in both color and red-free photography, as you can see here. Angioid streaks are bilateral, tapering, irregular lines which radiate from around the optic nerve. They may be circular or circumferential, pigmented, or surrounded by loss of pigment. These streaks represent fractures in Bruch's membrane, which contains elastic tissue and becomes fragile due to calcium deposition in this disorder. They may become complicated by neovascularization or choroidal neovascularization, as seen on the color photo on the left. One can see some faint angioid streaks in this patient with a central scar. There's some deep retinal blood and fluid surrounded by lipid deposition. That's the yellow deposits. The late frame from an ICG study on the right highlights the interlacing peripapillary that's around the nerve, angioid streaks, and the leakage that corresponds to the choroidal neovascularization. The peau d'orange is also easily seen. This patient had 2 prior laser treatments in this right eye and a central scar. This is the same eye 15 years later, suggesting in retrospect that additional treatment may have been of benefit to limit the size of the central scar, which resulted in a very large scotoma or blind spot. After my last presentation, I was asked about atrophy, as geographic atrophy has been a main topic of conversation being advertised on television and radio. Geographic atrophy is a chronic progressive degeneration of the macula. The disease is characterized by localized, sharply demarcated areas of atrophy of the outer retinal tissues, which include the photoreceptors, retinal pigment epithelium, and the choriocapillaris, which is really a capillary portion of the choroid. Here's a patient I first saw in 2013 as a participant in the phosphate binder trial. You can see the light area at the edge of the optic nerve in the right eye. It is better seen in the red-free photograph here on the right. This is the patient 10 years later with progression of the atrophy and a decline in vision from 2025 to 2100. This is one of my patients who was reported in the literature in 2008 by Dr. Stephen Sang with RPE atrophy as a cause of, in quotes, non-vascular loss of vision in pseudoxanthoma elasticum. This is a good example of well-circumscribed geographic atrophy. This brings us to strategies to prevent vision loss. We recommend a reduction of dairy products and avoidance of smoking, especially in patients who are predisposed to accelerated atherosclerosis. We recommend aerobic exercise to build peak bone mass, to reduce the risk of osteopenia and osteoporosis. Another good reason to avoid smoking, which also contributes to bone loss. Very importantly, eye protection, like wearing sunglasses or protective eyewear, especially when engaging in contact or racket sports, is important, as mild trauma can cause bleeding and loss of vision, which I have seen in several patients. Avoidance of the Valsalva maneuver has been recommended to reduce the risk of bleeding and subsequent scarring. The Valsalva maneuver is when one bears down and the face turns red, like while straining during bowel movements or heavy weightlifting. Early detection is very important to reduce the risk of vision loss. It starts with the identification and education of patients at risk. This includes examination of family members for evidence of this recessively inherited disease and education information regarding symptoms to look for. It includes regular examinations by an IMD and routine review of the Amsler grid, reporting any sudden significant change immediately. We revisit the cartoon of the deep cellular layers of the macula to explain the distortion experienced when angioid streaks are complicated by choroidal neovascularization, or CNV. As I said, the choroidal vessels are separated from the retinal pigment epithelium by Bruch's membrane, which can become calcified and fragile. If dehiscences or breaks develop, these small ruptures allow the vessels from the choroid to grow under the retina, elevating the tissue layers, as you can see here. When the retina is lifted up by the vessels, which tend to leak fluid, the receptors are displaced and the image interpreted by the brain is distorted. Patients are provided with an Amsler grid, or it can be easily downloaded from the computer. If there's a decrease in one's acuity, or the grid develops distortion, or a blind spot or gray areas, patients are asked to report these symptoms immediately. Again, symptoms are what the patient experiences, which is different from the signs, which we'll talk about soon, which is what the physician observes. What methods do we employ to evaluate a patient in the office? We routinely begin by checking the visual acuity. The doctor performs a dilated exam looking for signs of choroidal neovascularization. These include blood, lipid, as you saw before, and fluid, which may be subtle. We perform photography, angiography, and use optical coherence tomography, or OCT. Here you see a color fundus photograph which reveals the peripapillary angioid streaks and the peau d'orange. The red-free black and white photo highlight the streaks, which are similar to blood vessels in appearance, thus the name angioid streaks, and the modeling referred to as peau d'orange. Autofluorescence photography uses a series of filters to bring out certain features like the angioid streaks. Fluorescein angiography easily demonstrates the angioid streaks and surrounding pigment atrophy, which impart a feathery appearance in this particular patient. Indocyanine green angiography can offer certain advantages over fluorescein. Due to the infrared wavelength, it better penetrates the pigment layer and a thin layer of blood. So it can better delineate angioid streaks, peau d'orange, and occult or hidden neovascularization. OCT is an abbreviation for optical coherence tomography. It is an invaluable tool for evaluating patients for evidence of active disease. It can take 100,000 pictures per second and generate a cross-sectional image of the retina. Here you see a 52-year-old with angioid streaks, a reticular pigmentary change, and pigment atrophy, the lighter areas. The vertical high-definition scan goes through the angioid streaks, and you can see subretinal fibrosis and subretinal fluid in this patient, as well as spickling of Bruch's membrane, some areas of pigment loss, pigment clumping with shadows where the light hits. Here's another example of OCT of a patient with a large area of subretinal fluid under the macula. This is right in the center of the macula, referred to as the fovea. The increased central thickness, which includes the measurement, including the fluid, is color-coded. The more orange and red and even white in the center can both document this for easy visibility for the clinician, and it can document it quantitatively for future comparison. So you can see the central retinal thickness in microns, this being 436 microns thick. Normal thickness might be 250 to 300 microns. The fluid is adding thickness, and a patient could be followed as they are treated. Which brings us to treatment. Thermal laser was the treatment of choice to cauterize new vessels that were not in the center of the eye prior to the advent of anti-VEGF or anti-vascular endothelial growth factor injections. We didn't laser the center of the eye as it caused a central scar, which was just what we were hoping to prevent. Although some studies suggested that lasering the center did give long-term benefit, it would immediately decrease the vision, and patients were not in favor of that treatment. The cold laser, or photodynamic therapy, was also used, but merely slowed the rate of vision loss. Surgical approaches have mostly been abandoned with the introduction of anti-VEGF agents. Most of the data from these anti-VEGF agents is extrapolated from studies of wet macular degeneration, which has similar pathology. I'll mention complement inhibitors, which may be considered to slow the rate of progressive geographic atrophy, but has not been studied specifically in PXE patients. We've studied phosphate binders and magnesium supplements in PXE patients, neither of which has shown statistical significance in the reduction of systemic mineralization, although there was a positive trend in the magnesium trial, which studied only 40 patients. When we cannot help our patients medically, a referral to a low vision specialist is a valuable tool in the management of severe disease. Biosimilars are defined by the FDA as a biologic product that is highly similar to a reference product, though it may have minor differences in clinically inactive components. It has to have no clinically meaningful differences from the reference product in safety, purity, and potency. I mention this because 2 agents have been approved by the FDA. BioViz, approved in September of 2021, and Cimerli in August of 2022, are 2 biosimilars that work the same as the reference product Lucentis. Biosimilars are not generics. They are equivalent to the reference product. They don't undergo the same study. They don't need primary outcomes going out to 1 or 2 years. They just have to act the same as the reference product over a period of 8 weeks, and during those 8 weeks of testing to show that there aren't any safety issues. Since their introduction, no reports of any major issues related to their use have emerged. Biosimilars have the potential to lower costs and improve access to medications for physicians, patients, and payers. For the treatment of choroidal neovascularization, they have not yet been widely adopted, and that is perhaps we do have the option of using Avastin, an off-label agent, which is less expensive than Lucentis, which is the reference product that we mentioned. Complement inhibitors are indicated for the treatment of geographic atrophy in age-related macular degeneration. Syfovre was approved by the FDA in February of 2023. Results of the Derby and Oaks trials showed that the drug, given monthly via intravitreal injections over 24 months, slowed the lesion growth by 22%, and given every other month by 18% compared with sham. There has been a Gale extension trial that showed an even better response in months 24 through 30. There have been several cases of inflammation and retinal vasculitis reported in recent months with this medication. Izervay was approved by the FDA in August of 2023. Given as a monthly injection, it was shown to slow the rate of progression between 18 and 35% in the GATHER1 and GATHER2 trials. This is an example of a patient, Dr. Stanley Chang, who did well with laser treatment while I was a fellow in training in 1984. The retinal hemorrhages, which can be seen several millimeters from the fovea, and the choroidal neovascularization at the fovea is seen lighting up in this fluorescein angiography. After both red, krypton, and green laser, the choroidal neovascularization is not stabilized, and the vision improved. However, 6 months later, a new area of leakage was noted on clinical examination and confirmed on angiography and was treated. The recurrence rate was very high after laser, as high as 60 to 75% over a 3-month period, and it did cause a scar, so we did welcome the anti-VEGF agents. This is a 48-year-old artist who participated in the phosphate binder trial. 1 year after the study was completed, she noted decreased vision in the right eye. Note the hemorrhage near the fovea and the subretinal fluid, which is subtle, but obvious on the Stratus OCT, an older version of optical coherence tomography. The hemorrhage and fluid were more apparent on the red-free photograph. The hemorrhage here and the fluid outlined by my cursor. This was in July of 2006, several weeks after Lucentis gained approval from the FDA for treatment of choroidal neovascularization. This is how she looked after 3 Lucentis injections, with her vision returning to 2025, where it remained for at least 9 years, which is when I last saw her. This 49-year-old web designer was noted to have a hemorrhage, a small dot hemorrhage, nasal to the fovea on her 12-month visit during the magnesium trial. OCT revealed the central scar with fluid nasal, temporal, and superior to the fovea. She had been diagnosed by neck biopsy at age 16 after trauma to her right eye during a judo competition, which resulted in a retinal hemorrhage, hospitalization, and vision loss. Here are several other deep retinal hemorrhages surrounding her angioid streaks. This is an OCTA or OCT angiogram revealing the central scar and choroidal neovascularization in the avascular zone. You can see that flow is demonstrated in the central scar. 6 years ago, she presented with decreased vision in her left eye with retinal hemorrhages and fluid on OCT. You can see cystic and subretinal fluid. She responded to an anti-VEGF injection with reduction of the fluid on this high-definition OCT study. 9 years after initial treatments were started, she has had over 30 injections in the right eye and maintains 20/50 vision, with more than 20 injections in the left, where she sees better than 20/30. She has been treated with both Avastin and Eylea. The future looks bright for treatment of the ocular complications of PXE. We can look forward to better therapeutics, including longer-lasting agents, improved delivery systems, and artificial intelligence to help guide our clinical decisions. We continue to explore new therapeutics like TNAP inhibitors and enzyme replacement therapy. There are currently stem cell trials underway, as well as scientists studying transplantation of the retinal pigment epithelium. The ultimate therapy may be some form of gene therapy to truly prevent both the systemic and ocular complications from this disease. Gene therapy holds the potential to alleviate the treatment burden by delivering sustained and enduring therapeutic effects through the production of endogenous anti-VEGF within the retina. The prospect of reduced treatment frequency offers benefits for patients, including substantial enhancements in quality of life, vision preservation, and a reduction in the socioeconomic impact associated with vision impairment. In summary, I have reviewed the clinical manifestations of PXE in the eye and presented the diagnostic tools with which we identify and evaluate patients at risk for vision loss. I discussed strategies to prevent vision loss, the treatment options, and illustrated some key points with case presentations. Anti-VEGF agents stabilize a majority of patients with choroidal neovascularization. The take-home points are physicians must treat early with careful follow-up. Patients must be educated about symptoms to report, such as decreased vision, distortion, and blind spots. Physicians must look for signs on exam, which include blood, lipid, and fluid. And better modalities are needed in the future for the preservation and treatment of the ocular complications of PXE. Thank you for your attention.
Great. Thank you very much, Wayne. As usual, very informative. Great to have a new update on some of the newer therapies. So the floor is open for questions. You can either unmute or raise your hand using the Zoom function, whatever works for you.
You raise your hand. Yes.
Bob, you are unmuted. Bob and Pam.
Sure. Hi. Thank you.
Hi.
Dr. Fuchs. Thanks for your time today.
Thank you.
So I guess I have a few questions around the prevention. You mentioned magnesium. I take a combo, magnesium, calcium, zinc. Is there a recommendation like that's not good enough? Is there a certain dosage? What's it all about, I guess, the magnesium piece?
Well, the magnesium piece, we're going to leave the dosage. As I said, it did not slow the systemic mineralization in a what we call a statistically significant way. That if you listen to the previous talk about clinical trials, you have to pass a certain test where there's a p-value of less than 0.05 or 1 in 20 by statistical chance. So it did show a trend. So some people are taking magnesium supplements. The dose I'm going to leave to, and I have in the past, Dr. Mark Lebwall to recommend a dosage. He was the lead investigator in that trial. But some of the supplements you're mentioning, we have used in age-related macular degeneration. I mentioned a similar pathology, choroidal neovascularization. So there was a study called the AREDS-2 study, which there was an AREDS-1 study and an AREDS-2 study. AREDS-1 did have antioxidant vitamins in it, which would include beta carotene, which converts to vitamin A, vitamin C, vitamin E, a little bit of zinc, and some copper. And it showed a reduction in the rate of dry macular degeneration converting to wet macular degeneration. The reduction was about 20% in high-risk patients. There were then studies that came out that vitamin A was not good for smokers. There had an increased incidence of lung cancer. That study was verified. There were 3 studies. So we then studied, launched the study AREDS-2, which substituted lutein and zeaxanthin for vitamin A, for beta carotene. And that was equivalent to AREDS-1. So since there are many smokers, many former smokers, many secondhand smokers, and lots of air pollution and smog and things like that, we don't know what effect these things have on the risk of lung cancer. So we recommend AREDS2 supplements to reduce the rate of wet macula in patients at high risk. Of course, this has not been reproduced in PXE patients. They have not been studied in this manner, but so we do talk about antioxidant vitamins, or I mentioned a healthful diet just containing lots of vegetables which have antioxidant vitamins in them, green and orange for the most part. So I hope that answers your question, but I didn't give you the exact dose for magnesium. I apologize for that.
Yeah, that's okay. I just had two other questions. So I currently take Eylea, and I've noticed a lot of commercials about Eylea HD, the new. I'm always hesitant, taking something new. Is
Right.
that something if Eylea is effective, just stick with it? Or is there a reason I should be looking into the Eylea HD?
Okay. So it's a great question. Thank you. Eylea HD. So there are two new medications. Let's call them the second generation of anti-VEGF agents because they can potentially last longer. Lucentis was approved in 2006, made by Genentech. Eylea, 5 years later, made by Regeneron. So now about 5 years ago, a drug was approved called Beovu, and that was by Novartis, and that worked very well, but had some complications. I mentioned vasculitis with one of the new agents we used for geographic atrophy. So there was some many cases of vasculitis and vision loss, retinal artery occlusion with Beovu. So that drug is not used. So then the next longer lasting agent was approved about 2 years ago called Vabysmo, and that's made by Genentech. And in August, available this past September 2023, Eylea HD was approved by the FDA. So you're asking me, you're on Eylea, switching to Eylea HD, you're not actually switching medications, you're just getting a quadruple dose of Eylea HD. So who should consider switching? Here, the advantages are, of course, a longer duration between treatments, less of a treatment burden on the patient and physician. So the only disadvantages are two. One is if someone has severe glaucoma, we do inject a slightly larger volume with HD. In Eylea that you're getting, we inject a very small volume, 0.05 cc's, which is 1/20th of a milliliter. In Eylea HD, we inject 40% more, 0.07, and that can raise the pressure a little more temporarily. Not a good thing to do in patients with severe glaucoma, but most patients tolerate it well. Number two, if your insurance is Medicare, and I don't know if this translates to other insurers, but Medicare has approved the new formula HD because it lasts longer. So they've also told the clinicians, listen, guys, we're approving this more expensive drug, which lasts longer, so you have to use it less frequently. In other words, after 3 monthly doses of Eylea HD, they will not reimburse the 4th dose in less than 8 weeks. I think there is some leeway, 7 weeks to 9 weeks, but so you can't, let's say you need an injection on month number 4, we have to switch back to another medication. So that's just a little bit inconvenient. You start switching medications back and forth. So we don't generally change to HD if someone's doing very, very well. I've introduced it in a few patients. I have extended a little bit. It hasn't been impressive. On television ads, they talk about Vabysmo, which would be a switching medications for you, and they mention in the television ad, and I think I may have heard it on the radio also, that it, in quotes, can last 4 months. But if you read the study, if you want to use Vabysmo, you have to give it the study proved after 5 monthly injections that 3/4 of the patients can go 3 months. So I'm not sure where they're getting this 4-month information from. Of course, anybody can last 4 months if they're lucky, if their disease is quiescent, if they happen to have a non-virulent neovascular disease. So some of the ads are misleading. It is helping. It is extending the period between treatments, but there are those 2 disadvantages that I mentioned. And if you're doing real well and you get a shot 3 times a year, I would not talk to a patient about switching at that point.
Okay, great.
Thanks, Wayne. And remembering that everything that Wayne says is general, not specific to any one person. So we're going to keep the questions and the answers, which he's done, to general information. Question from the chat, Wayne, do you recommend geographic atrophy treatments at this point in time? And I think one of the confusions that some people have, having seen the ads come out on TV and so forth, is that, oh, they should be doing preventative ones, even if they have wet macular degeneration. So maybe just making the point about both of those kinds of macular problems and what treatments would be recommended at this time.
Well, so I do use both new agents, Syfovre and Izervay. They are for patients who we have a long discussion because, as I mentioned briefly, Syfovre, they're both new. Syfovre's been out just over a year, and Izervay was also approved in August of 2023, along with Eylea HD. So we have 2 agents for geographic atrophy, which is a form of dry AMD. That's the study group, dry macular degeneration, not PXE patients. And it merely slowed the progression rate of GA. But it is the only thing we have to offer them, so it's a good start. In patients that it's been approved for geographic atrophy, even if it involves the center of the eye and or satellite lesions, it seems that once someone has involvement in the center of the eye, the geographic atrophy is much slower to progress than if we have these, we call them juxtafoveal, near the fovea, geographic lesions. So we do use it after a long discussion, and we talk about the fact that it does not reverse anything. It does not stop the progression. It merely slows it down by 18 to 22%. That's the Syfovre data. And it is a commitment for an injection every 2 months or monthly. And that it's not as rewarding as our treatments for wet AMD, where someone's leaking and bleeding and we give them a shot and 30 to 40% of the time they improve, or we could show them that the blood disappears or the fluid goes away. Here, we're just slowing down the atrophy. We take a picture once a year and show them that it progressed perhaps a little slower than it would have. But patients who have lost central vision in one eye and have the vision threatened in the second eye do sign up for the treatment. And I've had maybe 25 patients having this treatment, and some of them, maybe 3 of them, have opted out because they've been blurry for 2-3 days and they didn't like that, and they're senior and it was their better eye, and they just they're taking their chances. There have been cases, as I said, of vasculitis recently, which is alarming. I had one patient who had mild inflammation, thank God, and we're not injecting her again. And so with regard to using these prophylactically in a patient that has wet, prophylactically to prevent wet, there's no role for this agent. It doesn't reduce the risk of wet macular degeneration. It, in fact, increases the risk of wet macular degeneration, which is another risk factor. So the risk factor for an injection to slightly slow the growth rate, the risks include increasing the risk of wet macular degeneration. Of course, we have good treatments for that, but that means another set of injections. Number 2, the risks of infection, bleeding, and retinal detachment that we always warn patients about before we put a needle in the eye. And I would say there's new risk of vasculitis, and there was a case of ischemic optic neuropathy, but that may or may not have been related to an injection. So we do not use it to to reduce the risk of wet macula, we in fact increase the risk of wet macula with these injections.
Great. Thank you. I think you've answered this, but just because it's in the chat and I want to make sure that it is clear, is there a downside to using a geographic atrophy treatment to address macular degeneration for a PXE patient reliant on anti-VEGF injections for vision maintenance? Do these drugs work against each other? So I think the person is saying they have both dry and wet macular degeneration.
Okay, so we do use these drugs in patients who have a combination of dry and wet age-related macular degeneration. For example, I have one patient who did become wet after an Izervay injection, and we treated her with an anti-VEGF agent. So I have one patient who was getting treatments for both. He had both wet and dry, and I have two patients. I'm thinking as I'm speaking. We don't use both injections on the same day. That would be a lot of volume to put in an eye. I have had patients alternate. I have one patient comes in every 2 weeks for an injection at this point because we alternate eyes. But you can use them if a patient has both geographic atrophy and wet age-related macular degeneration. We can use it. Here's the problem, though. Sometimes, and we talked about this years ago, back decades ago, most of the patients were coming in with vision loss due to wet macular degeneration, hemorrhaging, bleeding. We tried laser, it didn't work in the 5% that we could laser, or it didn't work well. So we had a lot of people with vision loss from wet macular degeneration. Then rarely did we hear about anyone with atrophy. So what happens with wet macular degeneration and in patients with PXE with bleeding and choroidal neovascularization is if we dry up the lesion, sometimes we see pigment atrophy as a result of having dried up the wet macula. And that group of patients is not truly in the geographic atrophy category. So if someone has an area of loss of pigment because they had fluid, you dried up the fluid and there's some pigment loss in that area, that is not truly geographic atrophy. And those patients really are not candidates they would not have been enrolled in the treatment trial. So I hope that answers your question. So if you have atrophy secondary to wet macular degeneration, that's not the same as pure geographic atrophy.
Great. And a question, Wayne, did you say that people should avoid dairy products?
Well, I did say that, but I said that, I carefully said that in patients who have accelerated atherosclerosis, because we talked about this just before my talk, we're not recommending a low calcium diet anymore. It seems that it doesn't prevent anything. The calcium is leached out of your bone. So back in the day, we were talking about low calcium diet, but dairy products can increase atherosclerosis. For that reason, I include it, and I guess that is controversial. I still kept that in my slide, though.
Yeah, so PXE International is saying, please don't limit dairy products unless you have a different reason, like heart disease or something else that's, your doctor is recommending. Because we now have a lot of people who limit it. Years ago, they said to limit it. And now we have a lot of people 65 and older with severe osteoporosis because they took calcium out of their diet early on. Okay. Let's see. I think that's it for questions. Anything else? Anybody else? You all also know that we've done a bunch of studies, surveys of people's experience with these treatments that Wayne is talking about. And we're in the process of analyzing the data, looking at things like how often, how frequently people are having various injections and what the results are. There's also been some discussion in the community about how they're administered and whether or not, for example, betadine is used in the administration or not. And so those kinds of things Again, we have very little data on because all the studies that Wayne's talking about come from the macular degeneration community, which is 20 million Americans and probably 100 million people worldwide. And we have so few people with PXE that we have to extrapolate from the work. And another question in the chat, Wayne, what type of calcium carbonate or citrate?
Well, you just said not to restrict calcium. We're not going to take extra calcium, and I don't think.
Yeah, I don't know, understand. Bob, do you want to unmute and clarify what you're asking?
Sharon, this is Pam. There's like calcium carbonate, calcium citrate, like the different products you can buy if you're going to take a supplement. And I honestly don't understand the differences between all of them. I just listed two of them.
Yeah, so we're not recommending a calcium supplement unless your doctor's recommending it. The clinician says, your osteopenia or osteoporosis, which is rare in men, but still happens. And then they'll make the determination about which of these is the right one for the person to take. And I agree with what Wayne said, really trying to get stuff from our diet is the way to go, because there's actually whole controversy about whether or not supplements work at all anyway. And as he mentioned, the AREDS-2 study, absolutely, that showed some benefit, but trying to get, green leafy vegetables and vegetables with color and all the things that the American Heart Association, in fact, does a good job of telling us what we should be eating. So I don't know that we can say anything about the difference between the calcium supplements and what those different structures mean.
Okay, thank you.
Getting back to the betadine question, years ago, we used to get a lot of questions about the pain with injections. I haven't heard that. We do generally, I wash out, we use the betadine and wash it out at the end of the injection, because that seems to saves a lot of phone calls the evening of an injection about the discomfort. See, we're not worried about infection 2 hours after an injection. That we're pretty sure we can reassure someone on the phone, but they have a miserable night sometimes if we don't wash out the betadine.
Yeah, and the practices seem to vary a lot amongst retinologists. And so what we did is we surveyed people and asked them, what is the practice they're experiencing and what is their experience after that practice. So we have that data, Wayne, and we have not yet analyzed it. We're in the process. Okay, that I think covers all the general questions. Again, if you have any specific personal questions, you can email them to me, Sharon@pxe.org, and I can get an expert to answer them. If they're questions that should go to your doctor, then we'll recommend you do that. I want to thank you, Wayne, for presenting again. Always love that you are very clear and make it simple enough for all of us to understand fairly complicated both structures of the eye as well as the process of PXE in the eye.
Thank you. Thank you all.
Thank you. Have a good day, everybody, or evening, wherever you are.